you happy knowledge. Knowledge is friendship, wealthy, monsoon. And we all connectors are always everywhere to enjoy all seasons apart from dedication to our profession. But we know there are many monsters, enemies affecting health of the globe. One of the monsters, very sophisticated, looks very simple, very fair colored, but dangerous at any time. It just takes the chance to attack. You name any medical problem, it is there, like affecting globe, troubling doctors, threatening people, risking lives of the ANC patients and their babies, also provoking other monsters to create nuisance to our health. And the monster is anemia. But our OBGY people are tough fighters. You know, they are born tough. Our budding OBGY fighter, Dr. Diksha Gopal Krishna, has challenged the challenges of anemia to save pregnant lady and her unborn child. But this anemia also requires control from authority. And there are great warriors with us who are having different weapons, especially Brahmastra. Though we know it is destructive, actually it has been created by Lord Brahma. He wanted to ensure that all work in the cosmos should be carried out smoothly and under control. And in the same way, our great warriors, Dr. Virendra Kumar from Bellary and Dr. Anjali Kauthakar from Nagpur, they know how to handle this monster and when to where to use all each weapons. All efforts to protect mother and baby, along with preventing collateral damages, both having amazing work to defeat anemia. Welcome, Dr. Virendra Kumar, Dr. Anjali Kauthakar, and Dr. Diksha. Dr. Virendra also contributed one chapter of anemia in my book. Now, in this battle of health, we know there are some other enemies who are invisible. They will be creating nuisance everywhere, affecting genetics and planning many evil things. But you know, our OBGY world is blessed with many other warriors for different problems. One of such dashing warrior is Dr. Anu Udyamudi, who is having amazing words, amazing pulse of wisdom to deal with the roots of such evils. She is going to speak on genetics and of bad obstetric history and prenatal diagnosis. Welcome, Dr. Anu Udyamudi. Now,
Thank you, Dr. Sushma.
Now, such enemies need control from all other places, and our OBGY commanders are there to control them to make situation under control. I welcome Dr. Aparna Mahane from Akola, Dr. Kunda Shahane from Nagpur to chair this session for adding their wonderful inputs. We know that journey of mother and fetus is difficult. We need to be positive and to be ready to support and care in any adversity. Also, welcome all the audience, the PGs, and the respected seniors and friends. Dr. Krutika Kukre tried to collect all the warriors and their weapons for amazing effect. Our conveners, Dr. Anuja Bhalerao, Dr. Bhakti Gurjar, Dr. Prachi Dikshit are always there for n number of weapons and these tricks. Our NOJ secretary, gorgeous and efficient and always well equipped with all weapons. So let's enjoy this wonderful war. Thank you.
So now let us begin with a case presentation. I request Dr. Diksha to begin with a case. Thank you so much, ma'am. One and all.
So before the presentation, please introduce yourself.
Yes, good evening everybody. I am Dr. Diksha Gopal Krishna. I am currently in my second year at GMC Akola, doing my MS in obstetrics and gynecology. It is truly an honor to be presenting a case in front of such an esteemed panel this evening. Moving on, I will be presenting a case of one of the patients that we treated at GMC Akola. She is my patient Vishanti Sharma is a Hindu by religion, a 24-year-old woman, resident of Akola. She's been married since 3 years. She was referred from THW, the District Health Women's Hospital in Akola, in view of severe anemia. She was found there to have a hemoglobin of 5 gram per DL and was transfused with 1 pint of whole blood. She was also admitted there for a period of about 24 hours, therefore being referred to GMC Akola. She's a second gravida with one live issue, giving her the obstetric formula of gravida 2, para 1 and living 1. She has one daughter who is aged 1 year old, was delivered by uncomplicated lower segment cesarean section done in view of fetal distress. She came to our ANC OPD at GMC Akola for the first time at 9 months of amenorrhea. And this was her first visit to a tertiary care facility. She presented with complaints of weakness and easy fatigability since 1 month. She was apparently all right up to 1 month ago when she noticed that she was not able to carry out her day-to-day activities like her household chores and taking care of her daughter like she usually used to. She often felt lightheaded and exhausted from minimal activity and did not feel energetic even after rest. She also gives a history of moderate to severe nausea and vomiting in her early pregnancy, which thereafter reduced her appetite throughout these 9 months. She did not take any medical treatment for this condition. The patient has no history of bleeding per vaginum or per rectum or hematuria or bleeding for any other orifices. No history of bleeding or clotting disorders. No history of transfusion before the one blood transfusion given at DHW. Of blood on blood products ever before this pregnancy or during this pregnancy. No history of fever, cold, and cough. No history of breathlessness, palpitations. No history of loose stools or passage of worms in stool. No history of recent trauma or grievous injury. No premonitory symptoms of preeclampsia noted like headache, vomiting, etc. No history of drug allergies, intake,
Dr.
or drug
Diksha, why are you asking so many negative history? Is it always necessary to ask these things?
Sir, in this case, in which I'm suspecting anemia, first of all, because it's such a big problem in ANCs, I'm trying and figuring out if there are any possible reasons to rule out anemia in this patient, which will help me further to manage her case and to treat her further.
One or two, three relevant questions can be asked, but you cannot complete every cause of anemia in the presentation.
Okay.
So this should be kept in mind, especially if you are taking exams. If asked by the examiner, you can definitely tell the relevant negative history, but no need to ask so many negative history and waste time on this. Right? Okay.
The menstrual history, she had a menarche at 14 years of age. Her previous cycles were normal, other than the fact that she had heavy bleeding. She used to have slippage of 2 to 3 pads per day. Her last menstrual period was 19th of October 2022, which puts her expected date of delivery at 24th of July 2023. Gestational age by LMP came out to 36 weeks and 5 days, and by early scan came to 37 weeks and 1 day. Under obstetric history, she is.
Now, 1 minute. You are talking about LMP. Whether she had regular cycles after delivery, because you told that baby is only 1 year old.
Yes, sir.
Okay, that means she has conceived maybe 3 or 4 months after delivery. Whether she had any.
She had a short conceptional period.
Or she conceived during lactational amenorrhea.
She conceived during her lactational amenorrhea.
Then how her LMP will be 19, 10, 22 if she has amenorrhea?
This was her previous cycles before. I actually put this in to indicate that she had a very low iron stores as well in the beginning. Because
that is all right. Because since you have written LMP 19, 10, 22, whether she had really had menses after her delivery or she conceived during lactation period.
After her previous delivery, she had menses, but that was after previous delivery, she didn't have menses because she conceived during lactational amenorrhea.
Yeah, that's all. So then your LMP is irrelevant.
If she conceived in amenorrhea, she can't have LMP. Isn't
okay.
It?
All right. Grant.
How many % of women can have pregnancy during lactation amenorrhea? Patient will be surprised that she is pregnant if you declare that you are pregnant.
Right.
So what is the incidence of ovulation during lactation amenorrhea?
Don't have a number in mind.
Okay, so you should be aware that 15% of the women can have ovulation even during lactation. Okay, right. So you don't write LMP for if she's conceived during lactation. Okay.
She's a gravida 2 para 1 living one with non-consanguineous marriage. Her first child is 1 year old, a female delivered by LSCS, done with fetal distress. The procedure was uneventful. Patient was discharged.
No, you have written non. 1 minute. You have written non-consanguineous marriage. whether consanguineous marriage has any role in this in your case? Let us say, what is the relation of consanguineous and non-consanguineous marriage in your case?
Sir, consanguineous marriages usually have a lot of genetic defects that can come in along with blood.
No,
related
that is in general talk. In pertaining to your case, so for example, because there is positive time, I will answer. So, yeah, because some of the hemoglobinopathies can run in family. So history of consanguinity is very important. In case you start investigating the case and it turns out to be a hemoglobinopathy, then the importance of consanguineous marriage is there.
Yes.
Okay, go ahead.
She reports only 2 ANC visits throughout this
No.
pregnancy.
You elaborate on the section, cesarean section.
Okay.
Because in every obstetric case presentation, history of previous delivery is very important.
She has a female child of 1 year old delivered by LSES done in view of fetal distress. The procedure was uneventful and the patient was discharged on post-op day 4 with no post-op complications reported. She has a history of only 2 ANC visits throughout this pregnancy at a local PHC.
So you should have mentioned that patient did not use any contraceptive,
right?
Or doctor might have failed to advise her. We don't know. She has not used any contraception and she conceived during lactation period. You must always stress on that point.
Right.
Okay.
Iron and folic acid tablets were not taken by her. Injection TT 1 dose was given. 2 ANC scans are available only, and she has no anomaly scan available at present.
No, when did she consult a doctor? How she came to know she's pregnant?
She went to her local PHC for again complaints of. She went to her local PHC again with complaints of fatigue and tiredness and dizziness. At which time she asked her menstrual history and UPT was done routinely along with the hemoglobin testing. Her hemoglobin was at about 7.2 when it was investigated earlier. But it turned out that she didn't take her iron and folic acid tablets as directed because she, as I mentioned before, she had nausea and vomiting, which was troublesome to her in the beginning of her pregnancy. So she altogether avoided.
Diksha, one question.
Yes,
her hemoglobin was 7 gram and now it is 5 gram. So what happened? What do you think?
Ma'am, this patient had chronically low iron stores. And she's also not really.
All in hemoglobin. Is there anything happening in pregnancy? Is my question. Initially, it was 7. Now it is by last trimester. It is coming to 5.
Yes.
Is it accepted? Is it possible to have like that?
What is happening? What are the physiological changes? I am giving you the clue.
Hemodilution occurs during pregnancy. So HB falls by about 2 or 3 points.
So what are the 2 reasons for such a decline in the hemoglobin? One is dilutional, physiological dilution because of the increased blood volume. Another one?
Second, very important.
You yourself told the answer earlier. You just summarize it.
Or dietary deficiency as well.
Yeah, there is no supplementation at all. There is no supplementation at all.
Yes.
Okay, so because of these 2 reasons, moderate has become severe.
Yes.
Isn't it? Increase iron requirement. Pregnancy will have a more of iron requirement. How much is the iron requirement in pregnancy, Diksha?
About 1,000 grams is the requirement. Out of which
on an average per day, how much it should be?
Should be about 200 mg on an average per day.
How much?
No, do we calculate on 200 mg or elemental iron?
6 to 8 mg per day. 4 to 6 mg in the first 2 trimesters and about 8 mg in the third trimester.
So if it is 6 mg, why we are giving elemental iron 660 milligram or 100 milligram?
So, ma'am, that is also to help with the iron reserves if they're deficient, as well as to cope with iron losses as well.
Is it so? If you are giving 60 milligram, whether 60 milligram goes for the erythropoiesis?
See, first of all, ferrous sulfate contain, what is the composition? Suppose IFA, Government of India supply. How much IFA contain?
60 mg elemental iron and 400
No,
micrograms.
full salt.
Ferrous sulfate and folic acid.
How much it is? How much it is? You don't talk about elemental iron, talk about the total weight of the molecule. Is it 200 mg or 300 mg?
200 mg.
Huh?
200 mg.
Okay. Then 200 mg, how do you calculate the elemental iron? Is it different for ferrous sulfate? Is it different for ferrous fumarate? Is it different for ferric biglycinate?
It's different for different salts.
Okay.
The form of the method of calculation.
So which molecule has got highest elemental iron?
Ferrous.
Or which has got lowest? You can tell any of this. Say, as a obstetrician, our bread and butter and the most commonest prescription is IFA, right? Maybe you don't write IFA, you may write some other molecule, right? So you must know all these things.
Right.
So you must know what is the composition of elemental iron. You can go and study. And all those PGs who are attending, how much ferrous fumarate is the elemental iron contribution. So generally it is around 30 to 33%. So if you calculate 200 mg, 200 mg salt, 33% becomes 60 mg. So if the requirement is 6 to 8 mg, why you are giving 60 mg? You can give straight away 6 mg, no? That's what Madam Anjali Madam asked you.
Should we tell her answer, sir?
Yes. Whatever you
How
give.
much is getting absorbed? Diksha, how much is getting absorbed? Whatever dietary, whatever tablet, whether everything is getting absorbed, iron?
Not 100%.
How much is absorbed?
25% is absorbed.
No. It is only 10 to 15%.
Only 10 to 15. So that is the reason.
That's all. So nowadays,
so what is which program is currently being run by the Government of India? Very important program to prevent such a sad scenario. 5 gram at term. It is absolutely a tragedy for us as a health service. So which program is being run at present, Diksha? Since program. 2018, any program for a prevention of anemia all over India? Diksha, you are there?
Anaemia Mukt Bharat program.
Anemia Mukta. So in Anemia Mukta, can you tell me how much is the prophylactic iron dose?
The regular
prophylactic. Now, listen to the question I'm asking you by in this Anemia Mukta Bharat. What is the dose for how many days you are supposed to give prophylactic iron? Prophylactic is when patient is not having anemia, isn't it?
Yeah.
So what is the recommendation in that?
Actually, the tablets are prescribed over a period of 12 months, including 3 months of post-natal as well. So 9 months of
remember, it is you start in 4th month and you give 180 days during pregnancy minimum, and you give 180 days postpartum minimum. So remember, it's very easy to remember that way. Minimum 180. It's not that you should be giving throughout pregnancy, but minimum should be 180 during pregnancy, and minimum days even postpartum is 180. That is the prophylactic with 60 milligram elemental iron and 500 microgram of folic acid. With the color of the tablet, whether you have seen that tablet. Red color is the color of the tablet.
What is 6 into 6 into 6 strategy?
Sorry?
In continuation with Madam's question, Anaemia Mukt Bharat, what is the 6 into 6 into 6 strategy of Anaemia Mukt Bharat?
I'm not aware, I'm sorry.
Oh, you cannot tell like that. Anaemia Mukt Bharat is a very highly ambitional program of Government of India. See the very Anaemia
Mukt Bharat. Next generation of obstetricians won't be facing 5 gram at term with that.
Okay, because so you go and all of you go and study what is 6 into 6 into 6 strategy of Anaemia Mukt Bharat, because it can be asked as a long question in your paper. Not only about passing the exam, you must know what are the strategies which are being done by Government of India to tackle anemia, right? Okay.
Can
So
I
what is
add
the
2
difference
points
between?
here? Anemia
Yes, ma'am.
Mudbarak for the students. One is,
Yes,
you
ma'am.
remember, deworming is included. It's not only the
Yes.
iron supplementation. Number 2, most important for all of us, is deworming. So how do you do deworming, Diksha, in pregnancy?
Ma'am, mebendazole is recommended 100 mg given for 3 days.
How much? How much?
100 mg
Again?
tablets of mebendazole.
When will you give in pregnancy?
Preferably early pregnancy.
Can you give in first
No,
trimester?
no.
Second
Can you
trimester.
give it in?
Second
It
trimester.
is contraindicated in first trimester. You give in second trimester, deworming, single tablet. Okay. Third, which is from Anemia Mukta, I want all of you to remember, is there is a delayed cord clamping is included in that for us obstetricians, because we are there, we should know. So what is delayed cord clamping? When do you call it as delayed? Any idea?
Ma'am, 1 minute after the cord is clamped, 1 minute after the delivery of.
3
Yeah, 60,
it is 3
60
minutes.
seconds.
Remember, it is
Yeah.
you wait till cessation of pulsations or 3 minutes, that is delayed cord clamping. It is also part of this Anemia Mukta. So go through that program. It is beautiful.
Yes.
Are treating
Can you-
patients, deworming, we tend to forget. That is why we should be knowing that.
So what
Okay,
is the
proceed.
difference between prophylactic iron and therapeutic iron?
As in the medications would be different depending on the period of gestation.
No. If patient is not anemic, just to maintain the usual physiological requirement of iron, if you are giving any iron, so for example, patient hemoglobin may be 11, it is normal. Still, we give iron supplementation just to take care of the physiological requirement. If patient is anemic, then you start giving more tablets. For example, hemoglobin is 8, you start giving more. What is the recent understanding regarding therapeutic doses? How much maximum iron can be given per day?
6 to 8 mg per day.
No. Tablets.
Tablets, two of the government issued tablets. 2 tablets are given at max per day.
No. It is 1000. Earlier, if you read our textbooks, maximum dosage recommended 1200 milligram per day. That means up to 6 tablets of IFA can be given. So this is old understanding. New understanding is whatever you take, even if you give 100 mg, even if you give 200 mg, 300 mg, only 10 to 15% is absorbed. Okay, and the absorption is maximum 6 to 8 milligram. It is not like if you give 200 mg, only 10, 20 mg will be absorbed. So because of these things, even patient is anemic, whether she is not anemic, there is no need to increase the dosage. That is the recent understanding. Okay. So just because patient is anemic, you cannot give 2 tablets thinking that it will work more. So recent understanding is, in spite of having high anemia or the severe anemia, you need not give 3 or 4 tablets because patient will never tolerate that. And as in your case, she was given tablets because of the GI side effects, she discontinued. So this is because there is a, are you aware of hepcidin mechanism? What
Yes,
is
sir.
hepcidin? Yeah.
Hepcidin and
Because-
absorption of iron are an inverse relationship.
Yes. Okay. Because of the understanding of hepcidin mechanism, whatever you give iron, even little iron you give, immediately hepcidin level is increased. Okay.
Yes.
The moment hepcidin is increased, it is subsequently decrease the absorption of iron, irrespective of whether patient is having anemia or not.
Right.
So because of hepcidin understanding, which is of recent 5 to 10 years knowledge, our textbooks need to be rewritten because of the hepcidin mechanism. Whatever iron you take, you take first day, second day hepcidin is increased. If you take the second day tablet, it is not going to be absorbed. All this iron is dumped into the GI tract. So that's why our IFA program is a failure. Earlier, we were not aware of hepcidin mechanism. Okay. So how do you overcome this hepcidin? If you take iron tablet, hepcidin immediately increases in the body and subsequent doses are not at all absorbed. That's why we are seeing, in spite of dumping tons and tons of iron in the body, there is no improvement in the hemoglobin, and we obstetricians are frustrated looking at our patient. Very few people are maintaining their hemoglobin. Majority of patients, their hemoglobin do not improve at all. Most of the patients. Then what is the strategy?
Try and increase absorption at the
Yeah.
source. An acidic environment, ascorbic acid.
Yeah, they're all prerequisites. In spite of all those maintaining, like for example, you don't take with the food, you don't give tannins, phytins, don't take with along with calcium. All these things are in spite of this, because of the culprit of hepcidin. It is an inflammatory marker. So the strategy is now give alternate days.
Okay.
Don't give daily. You confuse the body by not producing the hepcidin. You give today, the moment hepcidin increases the body next day, that day don't give iron. So hepcidin comes down. Again, next day you give it. So this is the strategy. Instead of giving daily iron, which is going to increase the hepcidin, give alternate day regimen. So you are increasing the compliance. Patient is very happy because she need not take daily. Okay. And you are giving alternate days. This is one of the major strategy proposed by researchers all over the world.
Oh.
And there is also thinking of inventing a molecule which is independent of hepcidin. Can you tell me the molecule? We are discussing about iron therapy during pregnancy, which is very, very frustrating to the most of the practicing obstetricians. Because patient comes once in a month or once in 2 months. In our busy practice, we may not be able to look for the compliance of the patient. And sometimes we may not be doing every month hemoglobin percentage. Very few people, highly motivated, 10 to 15% of the patients consume iron regularly. 80 to 90% they don't consume. And these patients are seen by not doctors. 80% of the women are not seen by qualified obstetricians. That's why we have to think of alternative regimes, how to improve the anemia. One of the best strategies is giving infrequently. Instead of giving daily, you give once in 2 days or once in 3 days, or even weekly regimens are also recommended. It is also there in Anaemia Mukt Bharat. So all this revolves around the concept of hepcidin, or nowadays they are thinking of a newer molecule which is independent of hepcidin. Can you tell me that? What is that iron? See, being a postgraduate, you must be aware of what are the recent advances. What iron? Which iron? For example, can you tell me the molecules? What are the different molecules?
Sir, under the
Iron preparations.
parental iron?
No. Oral iron.
Oral iron can be ferrous sulfate, ferrous fumarate.
Yeah. What is the current molecule which is being prescribed most often by most of the gynecologists all over India?
Most often is ferrous sulfate.
No. I am telling obstetricians. Prescribed by, not by government of India. Any other molecule? Ferrous sulfate, ferrous fumarate, anything else?
Ferrous
I will
ascorbate.
give a clue. Vitamin C.
Ferrous ascorbate.
Ferrous ascorbate. So it is playing a long role since almost 10 to 15 years. It is a darling of many obstetricians. Like that, can you tell me any other molecule? It is, I will tell you the answer. It is a liposomal iron or sucrosomial iron. Okay. So this is thought to be independent of hepcidin. Okay. Ferroportin molecule is required for all other iron molecules. Ferrous, whatever, whether you take ferrous ascorbate, all those things. Sucrosomial iron, otherwise called as liposomal iron, is independent of hepcidin mechanism. It has got a better compliance. Only we need to do a lot of research on this. If that becomes really fascinating, then our anemia will be definitely solved. So the molecule name is ferric pyrophosphate. Understood? Ferric pyrophosphate. It is also called as liposomal iron or sucrosomial iron, which is independent. It is actually absorbed by endocytosis, unlike other your routine ferrous fumarate or ferrous. Okay, continue, madam. Anything you want to add
Yes, one
regarding
question.
IFA therapy?
We are concerned about anemia, or in other words, what is the effect of anemia on mother and
Yes.
what is the effect of anemia on baby?
On the mother, it can start with something as mild as fatigue or not able to carry out her day-to-day activities. Severe anemia can lead to complications like pulmonary edema or cardiac arrest as well. And supplementing or transfusing blood as a
No, no, be
treatment for
specific. You can't tell cardiac arrest. They are prone for
congestive
congestive cardiac failure mainly, and quality of life is affected. So instead of directly telling
Cause
death
of
of a
death
woman,
is one is cause of death. You said maternal mortality will be because of the congestive cardiac failure. Any other way the anemia kills, it is called as a silent killer. All of us call anemia as a silent killer. So what is happening? How
anemia
it
comes under
contributes?
which category of maternal mortality? There are two causes of maternal mortality. What are those two causes? Always divide maternal mortality into two causes: direct causes and indirect causes. The main contributor of indirect cause of anemia is anemia. Okay. What are the direct causes? Can you tell me? What are the direct causes of maternal mortality?
PCF like in anemia.
Huh? No. Direct cause of maternal mortality.
The maternal mortality 1, 2, 3, 4. It should be at the tip of the tongue, huh, Diksha? This is
One
number
is
one
PPH,
cause of maternal mortality in India.
Yes.
postpartum hemorrhage. Number 2 is eclampsia or hypertensive disorders. Number 3 is sepsis. They are the direct causes. Anemia is one of the indirect causes. You answer madam's question. What is the effect of anemia on mother?
You should divide it in pregnancy, labor, and postpartum. Like that, it will be easier for you to remember what are the various complications and how it increases the morbidity as well as mortality. Then come to the how it affects the baby on the fetus.
For the mother,
What is the effect of anemia on mother? You divide it always. Whenever that question is asked, always divide and try to remember that way. First half of pregnancy, second half of pregnancy, labor, postpartum. So that you don't miss out on anything. Just you can't say one has congestive cardiac failure. So many things are happening.
What is the effect on baby?
On the baby, specifically when it comes to iron deficiency anemia, the baby is usually supplemented with enough iron, as in there is no anemia seen in the baby in most cases.
What is the reason? What is the reason, Diksha?
Because iron is transported against the concentration gradient to the baby.
What is double Bohr effect? Any idea? What is oxygen dissociation curve, in other words? What is happening to oxygen dissociation curve on maternal side of placental circulation and fetal side? That you should read. Okay, that is the basic cellular level. Why the baby is not getting, why we are not getting fetal anemia. So, but what is the effect on baby? Apart from that, baby might not be anemic in most of the cases, 99%.
The baby could have IUGR.
Yeah,
Yes.
correct.
Retardation.
Yes. And one more.
Not retardation, is a restriction. Nowadays, the word retardation is not used. It is called as FGR, fetal growth restriction.
Restriction. And number
See,
two,
if
major
you
cause
utter the word retardation, it is like causing mental retardation, right? So don't use the word retardation. It is called restriction, right?
Yes.
And second, effect of anemia, which leads to so many times leads to perinatal mortality. It is
Most
preterm
of
birth.
these women will have preterm labor.
Preterm birth.
Preterm birth.
So it is
Anything,
both of
any
these.
long-term issues? What are the long-term issues? Even low birth weight, this is all right. But what are the long-term?
It leads to lower iron reserves in the baby as well,
Yes.
leading to furthering of worsening of
It is
anemia.
called as latent anemia. It is called as latent anemia. Apparently, hemoglobin may look normal, but they are devoid of good iron stores in their body. So that means we are producing a generation which has got a defective iron stores. So it is a responsible obstetrician to produce a healthy generation, right? Anything else? Babies born to anemic mothers are more likely to have adult onset hypertension. This study was done in during the great famine of Spain in 1950. Okay, so that means you are also causing adult onset hypertension. They may become schizophrenic, they have psychological disorder, and most importantly, there is intellectual disability. If there is,
Cognitive defects are also there.
yes, if mother is anemic by the time she reaches 30 weeks, it is called as iron dependent neurogenesis. Okay, iron dependent neurogenesis. So if at all you want to correct the anemia, always correct before 30 weeks, because after 30 weeks, neural development is enhanced in the presence of iron. If you don't give proper iron, or if you don't maintain the healthy hemoglobin, babies are going to have attention deficit disorder or neurocognitive delay in their development. So because of these reasons, always make it a point to treat the anemia before 30 weeks by whatever means, by good iron or changing the iron strategy or using the parenteral iron, whatever. It is your responsibility to see that by 30 weeks, her hemoglobin and her stores should be all right. Yeah, continue.
The latest USG findings were such. The cardiac activity was normal. Placenta was found to be normal with no retroplacental clots or any abnormality. AFI was adequate. Fetal biometry is corresponding to gestational age, and estimated fetal weight was 2,700 grams. Under past history, she has.
No, you can skip this and go to. Yeah.
Exam.
No, before that, very important, some of the examiners may ask, you tell me about her dietetic history.
Yes, so that's what I put in here. She has a mixed dietary intake, which included vegetarian and non-vegetarian diet as well. But her appetite was generally reduced from the very beginning. Approximate calorie intake was calculated to be only about 1,900 calories.
Now, how did you arrive at this 1,900 calories? Have you made a chart?
I don't
No, you wrote 1,900. No, is it like really calculated or is it approximate?
It was approximate.
You heard sometimes if you get an anemia, sometimes they may ask whether you know how much she eats food type of calories, and ultimately you must write what is the cause of anemia, whether it is because of insufficient intake of proteins or insufficient intake of total calories. So how much she is supposed to take calories?
A total of 2,500 calories is the demand for pregnancy.
Okay. So otherwise, during pregnancy, you added the extra calculation. How much extra calories she must take during pregnancy, apart from non-pregnant status? According to ICMR, how much extra calories a woman should consume after during her pregnancy? No idea? Go and read. Right.
The rest of her history is not.
Positive.
So how do you actually?
You can go for any positive findings on your general examination and systemic examination, so that we can start, sir, with the next part.
Yes.
On general examination, the patient was found to have pallor present in the mucosa and conjunctiva, oral mucosa and conjunctiva. And she had bilateral pupil edema as well.
Suppose patient is in the habit of chewing betel nut.
Sorry?
Betel leaves, pan. So her mouth is red. So mucosa is also you cannot assess. Yes. And what if she has applied kajal on her eyes? Then how do you see? And nails, she has painted with nail paint, nail polish.
To some extent.
How do you look for the anemia?
With the palm, but then even then that is not a.
No, she has applied mehendi. Just now she finished her program. How do you see?
That happens in practice. That is why sir is asking.
You see, literally, our body is covered with paint. How do you see? Which is the best place to see for anemia? You are a gynecologist. I'm giving a clue.
So when we are examining the patient, we can even see pallor in the vaginal mucosa.
Yeah, vaginal mucosa, because that is unlikely to be affected all by this cultural things. Okay, just you must be aware. Doesn't mean that you have to do per speculum examination to see anemia. right? Okay.
Over systemic examination, the patient was found to have a hemic murmur at the cardiac apex.
Okay.
Apart
What
from
grade?
that,
What grade? What was the grade of the murmur?
murmur was very mild murmur. It was actually not very appreciable. Our senior actually told us that there is a possible murmur, and we had
Know the grade, Diksha, and just remember, you read about the grades and some above which is usually associated with organic heart disease, because she can very well be having associated heart disease. Who knows?
yes, yes.
Yes.
Isn't it? It's very important.
It
because
can be a
it's-
deadly combination, heart disease and anemia.
And you can miss it just because you are focusing on anemia, you miss it and you have a death in your hand if there is a combination like that.
Yes.
All these combinations, anemia and hypertension in pregnancy, anemia and heart disease, these are all challenging and they do come
Yes.
together, isn't it? So you should know, in the CVS examination, you should be very particular.
Yes. No other abnormalities were found. Per abdomen, uterus was full term corresponding to period of amenorrhea. It was relaxed. Live was longitudinal cephalic presentation. FHS was normal and regular. Life was clinically adequate. This scar was seen at the LSCS site, and there's no scar tenderness. Otherwise, her examination was unremarkable.
So don't show the investigations. Don't show this slide. How will you investigate? We stop here. How will you investigate your case now?
Ma'am, the routine battery of tests that we do for all ANCs, which includes complete blood
You are
count.
having a 5-gram hemoglobin at term, isn't it?
Yes,
You
but
are
that was on her referral, so we just had to run another CBC just.
So that is the reason I'm asking you what investigations you would like to do now.
Primarily a peripheral smear to look into.
Any other better answer? Better answer?
Better, which is mandatory investigation, one single investigation, mandatory.
Which includes your peripheral smear as well.
A complete blood count.
Yeah, complete hemogram.
BC was the first.
You have to tell the answer, complete hemogram, which also includes peripheral smear.
Now you tell me how you can have a clue whether there is a hemoglobinopathy or whether it is iron deficiency when you look at a hemogram. What are the signs and what are the things which are indicating?
If you are able to supplement iron, if you are able to supplement iron and the reticular sign.
I'm asking you, have these patients TBC suppose in your hand, where will you focus? Because you are also worried whether she has a hemoglobinopathy. She can very well be a case or might be a case of sickle cell disease. Who knows? So what you
or
will
she may
see
be having thalassemia. We don't know.
Thalassemia. She can have a thalassemia associated with nutrition deficiency.
So how do you know that just based on CBC, you can tell that she may be having this kind of disease? So suppose how do you detect?
CBC carefully.
Yes.
On peripheral smear, we can identify sickle cells in case the patient is.
That is one. CBC is the long report, isn't it, Diksha? You have seen CBC reports?
Yes. There are also the blood indices.
Yeah, what are the blood indices? For example, MCV, mean corpuscular volume.
Mean cell volume.
Suppose if it is 105. Suppose if it is 105, what is your inference?
That it indicates a bigger volume, which means that there are macro sites in the blood, or the RBC sizes have increased, which could mean that she has abnormal cells in the blood.
No, what does it indicate?
Could indicate spherocytosis or macrocytosis in case of.
No, it indicates it could be B12 deficiency. Very simple. Always think of simple diseases first. Think of. Okay. What is Menzer index?
Sorry, sir?
What do you mean by Menzer index? MENTZER. Where it is used?
Very helpful for us, where you can't go for expensive investigations for each case.
Okay, you can go and read, because all things cannot be told by us.
Yeah, and that is, you should know the Menzer index. You should know the various things. What happens to RDW if it is a thalassemia minor? How you differentiate on the basis? What is RDW, Diksha?
It's the red cell distribution width.
Isn't it? So what happens to RDW in iron deficiency anemia?
Iron deficiency anemia, ma'am, there is microcytic anemia. So
What happens to RDW is my question. What is happening to RDW? Distribution width, na? That is, I'm asking you that. Just looking at RDW, you can say that it is likely iron deficiency. It is most likely thalassemia minor. So that is why I'm asking you. And you should see RDW in each CBC report.
RDW increases in iron deficiency.
Very good. And whereas in thalassemia minor,
Reduces.
it is normal. RDW is normal in thalassemia minor.
Just
go
excuse me
back and
for
read.
interrupting in between. Yeah.
Yes, ma'am.
We have already overshot some time. At maximum, we could take 10 minutes more.
No,
Yeah, yeah.
Raji, I think we need, no, I think we won't be able to give justice. Anemia needs at least 2 sessions, isn't it, sir?
Yes, ma'am. We will definitely consider this. We can go ahead with the second session.
Surely,
Yeah, in 10 minutes we'll wind up.
You can't cover in 10 minutes, just 10 minutes.
Actually, it is
can
very
understand this
interesting session. Very
Yeah,
interesting
quick
going on.
rapid
And we
questions
really
we'll
need
ask
one
to
more session.
Diksha. For Diksha, we'll ask rapid questions, and if she doesn't answer, we will answer. Okay. Okay. How do you treat this patient?
This patient came to us.
Now
at,
the diagnosis is simple. It is a nutritional anemia. The cause of nutritional anemia is she has lost blood during cesarean section, which was not supplemented later, and she did not use contraception. She conceived. See, all these factors are there. Basically, for anemia, there is a simple classification. One is hemorrhagic anemia, hemolytic anemia, then infestation anemia, and mixed anemia, and nutritional anemia. Any anemia for that matter, you have to divide into these categories. Ask yourself whether this patient belongs to hemorrhagic anemia, whether this patient belongs to hemolytic anemia, whether it is because of the infestation or infections. The fourth one is nutritional, or it could be combination of all of these. So this patient has got 2 combination. One is nutritional, another is hemorrhagic, which is happened during cesarean section, because you know that there is a loss of nearly 800 to 1000 ml during cesarean section, which is never supplemented. Okay, this is how you go about, instead of causing vitamin B12 deficiency, thalassemia, aplastic anemia. That is theoretical. Practically means you have to have 5 these: hemolytic, hemorrhagic, infestation, nutritional, and mixed variety, right? Then, because patient is already come in a state where she is almost about to deliver, you cannot think of iron supplementation by oral route. You have to decrease the chance of cardiac failure by immediately improving the hemoglobin by giving blood transfusion, packed cell transfusion, right? What is trigger point? Trigger point for transfusion.
The point which you follow at your place.
Trigger point for transfusion.
Below 7 would
Yes.
warrant a blood transfusion.
Yes, 7 is the trigger point, below which you will definitely start transfusing, right? Whether you transfuse whole blood or packed cells.
Yes, that same question I want.
Yeah.
Why not whole blood transfusion?
Huh? I'm sorry, I didn't get the question.
Whether you will transfuse whole blood or packed cell.
Packed cells is a better option.
Okay. So why not?
No.
Because patients who are severely anemic are prone to a volume overload. So an over-enthusiastic sort of blood transfusion can cause a volume overload, and the patient could go into congestive cardiac failure.
What are the indications for transfusion?
Madam, 1 minute. I want to give a good message to all the post guys. There is no role of whole blood transfusion in modern transfusion medicine. It is always packed cells. You cannot sell better option. It is the only option. You have to give only packed cells. Right. Madam, continue, please.
So my question was, why not whole blood is one is you do not want to over perfuse. But second, what I want all of you to remember is, if whole blood is more than 48 hours, it has no viable platelets and it has no viable so many coagulation factors. So it is a misconception. I'm giving whole blood, that means patient is receiving RBCs as well as platelets as well as coagulation factors, is a wrong concept. Whenever we are infusing whole blood, that means you are giving only RBCs and unnecessary plasma, because it might lead to overload and failure. Okay. So what you need to understand is, better to give, if even if patient is bleeding nowadays, Even if it is one, previously we used to say acute blood loss, you can start with the whole blood. But remember that for that also FFP, platelet, and these packed cells giving separately is much smarter way rather than going for a whole blood. As sir said, there is no whole blood transfusion policy in modern obstetrics. This is the main reason that there are no viable platelets after 48 hours.
Okay, if patient had come to you around 13 or 14 weeks, as you said, she had vomiting, how would you have treated her? You know that this patient is not compliant, coming from a rural area. She says, I cannot take the tablets. How you would have treated?
If she is absolutely not willing to take tablets and not cooperative, not compliant, we can give her parenteral iron.
Yeah, which parenteral iron will give?
Most commonly, iron sucrose is prescribed.
Huh?
But there are other options. Most commonly, iron sucrose is
Okay.
prescribed.
How will you
There
give
are
iron sucrose? How will you give iron sucrose?
iron
Okay, patient is
sucrose
ready.
Is 20 mg diluted in 20 ml given over 15 to 20 minutes.
No, dose, total dose.
Iron requirement, you mean?
Yeah. There are two things. First, you will calculate what is the iron requirement. How do you calculate the
Total
iron
dose
requirement?
of iron required.
How do you
The
calculate the
formula is,
iron requirement?
The formula is 2.4 into body weight into HB deficit plus about 500 mg added for iron stores, replenishing iron stores.
Any simple rule of thumb formula, because obstetricians are very poor in mathematics. You start calculating the mobile or calculator. Any simple formula? For every 1 gram rise in hemoglobin, you need 250 milligram of elemental iron. Okay. Suppose if the deficit is 6 milligrams, 6 into 250, that is the total iron requirement. So in that case, if you are giving iron sucrose, how much you will give in a single sitting? Today she has come. How much you will give iron sucrose? You will give 100 mg, 200 mg, 300 mg, 400 mg.
But Diksha, you said 20 mg. You are giving 20 mg. Is it so?
200 mg. 200 mg.
Yeah. Yes. Because nowadays your brains are all MCQ brains. We need to tell the answer 100, 200, 300. Then you will recognize the answer, right?
200 mg.
Okay. So maximum how much it can be given in a week?
About 3 to 5.
And why not more than that? Why not more than that? Why not give daily if she has so much of requirement? What is the reason we can give more? Toxicity?
See, nowadays everybody is switching to FCM, right? Instead of iron sucrose. The problem is you cannot give total dose iron in a single setting. And I cannot ask the patient to come repeatedly to the hospital. And it's not a intramuscular, it is a intravenous. Big compliance problem is there. So it cannot be given more than 200 mg because it quickly saturates the ferritin, transferrin. If you give 300 mg,
saturated.
So a lot of free iron will be available in the body, and that can cause parenchymal damage to the liver. So that's why we cannot give more than 200 mg per setting. We have to allow the transferrin to get desaturated with iron. That's why you keep on giving once in 3 days. So this problem again is there in the clinical. I cannot ask the patient to come every once in 3 days. You just imagine the logistics. She has to come from a different place, get admitted, or be in there in the hospital. That's why newer iron molecule like what has come now. You can give larger dose. Ferric carboxymaltose. Okay, why it can be given so largely 1000 mg? Because it doesn't immediately saturate the transferrin. It is slowly released into the system. That is the reason. How much you can give at a time? How much FCM can be given at a time? It is 1000 mg. You can give at a time 1000 mg. Okay, that is a beautiful advantage of FCM, and it is also less.
Rise is also better. Rate of hemoglobin rise is better with FCM as compared to sucrose.
Yes. Any other newer iron molecule, which is cheaper than FCM, but as efficacious as FCM?
only used FCM here as.
Yeah. Nowadays we have iron isomaltoside, the newer molecule, which is almost available at the half the price of FCM. So iron isomaltoside. And recently there was a study called as a rapid iron study. It was done in Rajasthan along with our own, my alma mater, JNMC, JN Medical College, Belgaum. They are one of the researchers, rapid iron study, wherein they have studied FCM versus iron isomaltoside. It is also giving good results nowadays. It is exactly available half the price of FCM. Okay, so every obstetrician caring for anemic mother should be aware of these molecules, iron sucrose or FCM, and you can give FCM single dose to wherever it is possible. If patient is not affordable, nowadays iron sucrose is available in almost all the government hospitals. At least in Karnataka it is available. I don't know about Maharashtra.
Yes.
Yes, available. Yes.
Even
it is
at
available. Okay, so at least
referral units it is available. First
yes.
referral unit.
So what you can do is, instead of calling every 3 days, you can call once in a month. Every visit you can give 200 mg. So like 3-4 visits, she will get that 200 mg. And most importantly, what we are neglecting is most of our women, even though they are non-vegetarian eaters, they have deficiency of vitamin B12. It is better to give Vitcofol injection, which contains both folic acid and vitamin B12, along with iron sucrose or FCM during antenatal period. See, vitamin B12, it is very rampant even in non-vegetarian eaters because of the vitamin B12, whatever we eat is not absorbed because of the infection in the stomach. That factor, intrinsic factor, the deficiency is very rampant in India. Okay, and you must know. And what are the do's and don'ts during delivery? Severe anemia woman, what you should not do?
What are your goals whenever you see a patient in labor with anemia? Goals of treatment.
This is the last part of, because we're running short of time. I want to complete as
the patient is kept in a propped up position and supplemental O2 is given as and when required. Also,
Yes.
the duration of labor is tried to to be shortened with the use of
no induction of labor, because most of these women will deliver spontaneously. No induction of labor. If patient needs oxytocin, you should not give it in like 2.5 units in 5% dextrose or whatever, because again that is going to cause. You should use higher concentration oxytocin if at all they need acceleration of labor. Don't use routine 2.5 units or 5 units in 500 ml, because that can cause a lot of trouble and cut short the second stage. And routine practice of AMTSL.
Active management.
And all this, yes, all these women need to, yes, and restrictive episiotomy.
Go for epidural analgesia. That also might change the outcome. Yes. Epidural analgesia, if the facility is available, it is for these women especially you should go, because pain will lead to tachycardia and it will lead to more risk of going in failure, severe anemia.
So you must not use liberal episiotomy. You must be restrictive episiotomy, because the episiotomy itself can cause a lot of blood loss. Yes. She may not be able to tolerate even 80 ml or 100 ml of blood loss during episiotomy. So have a restraint approach for episiotomy, so that you don't make her further anemic. And all these women need to be given, irrespective whether they have received blood transfusion or not, iron supplementation in the form of parenteral iron should be given. And the contraception? See, all you are working in medical colleges, all students, please advise them contraception, advise them, take a minute, because you are always running without looking at their social background. Just complete the case sheet, write the discharge summary, take a 5 or 10 minutes important break and advise them regarding contraception and the importance of iron supplementation. They will definitely not take iron tablets. At least all medical colleges should give some iron to them intravenously and then send them home. This is the only way you can ensure better health among the population. Okay, contraception, I've seen people, because you are always busy with writing case sheets, everything, because I am myself a teacher, I know what are the problems. They never think of the future generation or future of women health in India. Take break, and definitely you must treat anemia and contraception. Very, very important. Had this patient been properly advised during her first delivery, this would not have happened. Okay, junior residents have an important role in improving the women health in India. Okay.
Yes.
Thank you, Madam Sushma, Madam. Thank you very much for
Sorry.
inviting me to share some information. Thank you,
So
Dr.
it was a
Bhakti.
wonderful discussion. Wonderful discussion.
ma'am.
Both you did very well. Diksha, you also did very well.
But Diksha, you need to read a
sir
lot.
and ma'am, very nice message. It was very interesting discussion.
Well done, Diksha, but you need to read a lot.
Yes, sir.
Okay.
Yes, I wanted the examiners to give tip for the presenter. So I think sir has added a word that
Yes.
the basic of subject which has lot to imbibe.
Hello, Prachi.
Yeah.
Hello.
Yes, Dr.
Yes,
Anjali,
ma'am.
please.
Just I wanted to share that we should all remember importance of screening echo. What I will say, see the anemia patient, mother.
Ma'am, your voice is breaking. Is it only to me?
And we are unable to hear.
Ma'am, your voice is breaking.
On mute, ma'am.
Till now it was working fine. Just now
Yes,
it's mute now.
It's mute.
It's mute now.
Please unmute.
Yes, I had done. Okay. Is it am I audible?
Ma'am, I think there's some internet
Yes,
issue.
some problem in the connect.
Okay.
Suddenly, I just now.
Thank you.
But it was wonderful discussion. Very interesting.
Thank you, madam. Thank you.
And thank you, examiners. Thank you, Dr. Diksha. It was an informative case presentation. Now we move forward to our second session. Our second session is Pearls of Wisdom. It will be a informative talk by Dr. Anu Udimudi ma'am. And the topic is very recent and update and is very important topic. It is bad obstetric history and prenatal diagnosis. And the chairpersons will be Dr. Vahane ma'am and Dr. Kunda Shahane ma'am. So our speaker is Dr. Anu ma'am. Anuradha Udimudi ma'am is a PhD in human genetics and has 27 years of experience in medical genetics and has done her postdoctoral experience in USA labs from LabCorp and has received a Young Scientist Award at Environmental Mutagen Society USA. She has multiple publications in reputed journals and is a reviewer, author of medical book chapters. She is invited speaker at state, national and international conferences and has delivered about 350 plus lectures. She has conducted 200 plus genetic awareness programs in India and has designed world's first and most comprehensive NGS-based genomic panels for infertility and weekend pregnancy loss. She has presented data at ACMG 2019, ISAR 2021 and ASRM 2021. She has published up to 8 papers on genomic fertility analysis between 2022 and 23. She has delivered expert lecture at 15 plus IMA IVF training programs. So I welcome you, ma'am, for the speech. The chairperson for this session will be Dr. Aparna Vahane, ma'am. Ma'am is an inspiring presence for students. She has completed her undergraduate and postgraduate in OBGY from prestigious Indira Gandhi Medical College. And she is presently joined at GMC Akola as assistant professor in the year 1995 and is now currently in the rank of professor and has served as an inspector for both UG and PG for MCI and NMC of various institutes. She is mentor for fellowship in high risk obstetrics and minimal access surgery and is also a specialist member of various committees like maternal mortality, MTP committee, family planning procedures, etc. She is member of the curriculum committee and has been awarded for immense contribution in the services for maternal child health by the MS Signature Award 2020 for phenomenal leadership and has also done distinguished work during COVID and is also awarded by the COVID Warrior, by Akola Guardian Minister and various other NGOs. She has published multiple articles and papers in esteemed medical journals and encourages her students to actively participate in academic events and under her able guidance. I welcome you, ma'am. The other chairperson is Dr. Kunda Shahane, ma'am. She's a fetal medicine consultant and has done her fellowship in fetal medicine from VS Medical College, Ahmedabad, Gujarat, and is FMF certified. She did her post-graduation from GMC Nagpur and is director and consultant at Mayflower Fetal Medicine Center, Dhantoli, Nagpur. She is practicing in Nagpur as a fetal medicine consultant since 9 years and has special interest in genetics, fetal therapy, and fetal ultrasound. Ma'am is a member of Society of Fetal Medicine India and is founder member of Society of Fetal Medicine Maharashtra. Welcome, ma'am. I request Dr. Anuradha ma'am to begin with the session.
Thank you.
Hello. Hello. Hello.
Hello, ma'am.
Yeah, I just want to interfere. Yeah. Before we proceed, I just wanted to
Yes, ma'am, we can
I
hear
think
you.
chairperson
yeah,
can start. I
you
think
can see
she's
I'm
not.
able to get back. Yes. I wanted to thank our examiners today. Then mostly they leave the session. So I just want to say a really heartfelt thank to Anjali Virendra Kumar, who have given such a good insight into such a common and as
कोणची फ्रँकी आलूची फ्रँकी आहेत.
am I audible?
Pragati, we can move back. Your voice is breakable. Actually, everybody is waiting.
Now is it okay?
Yeah.
I
But we
just
can-
wanted to thank Dr. Virendra Kumar and Dr. Anjali Bhandarkar because we couldn't Anjali Bhandarkar madam because we had short of time. We couldn't do justice to the topic, but such a nice inputs were given, and everyone has really updated their knowledge in for the most common cause, that is anemia. Thank you, sir, for joining and showing way to our PGs. Thank you so much. Thank you so much, ma'am. Yes,
Thanks
now
a
we
lot.
can continue.
Chairpersons, please, you can start. Chairpersons. Dr. Kunda, Doctor, please start the session.
Good evening, everybody. I am Dr. Kunda Shahane. I am consultant fetal medicine at in Nagpur. And today, after a discussion of fantastic discussion of anemia in pregnancy, we will proceed forward for the complex genetic topic, that is genetics in bad obstetric history. And we are very eager to hear from Dr. Anuradha ma'am, who is specialist in genetics. So we'll start that.
Hello, good evening, everyone. Thank you, Dr. Kunda, for introducing. Thank Dr. Sushma, Dr. Pragati, and also Dr. Prachi for inviting me. So I think I was given around 30 minutes, so I will try to put in the whole genetics in 30 minutes, although it's a difficult task to do. I will introduce the latest advances of genetics and genomics in obgyn practice. And I'll do that with the help of some case presentations. And I hope that will be useful both for practitioners and also for PG students. But just before I get started, I just wanted to mention that it was a very interesting case presented by Dr. Diksha. And also there was an interesting discussion on hepcidin. Now, this hepcidin function is also regulated by genes, and there is a gene called HAMP gene, which inherits in autosomal recessive fashion. And this particular gene, if it has a homozygous mutation on it, it results in what's called hematochromatosis, so which is a juvenile type of iron disorder. So I think, Dr. Diksha, you could also look up that, so that, you know, the hepcidin related genes could also be understood well for anemia related disorders. So let's go ahead with the lecture of what that I'm going to cover in my lecture today. So since Dr. Prachi asked me to cover complete bad obstetric history, I think we'll go ahead and talk about recurrent pregnancy losses, fetal ultrasound abnormalities, history of a child with birth defects, so void obstetric history, previous history, or children with autism and disability, mental retardation, neurodevelopmental disorders, or any kind of family history of genetic disorders, and consanguinity especially, and routine prenatal aneuploidy related screening also I will cover a little bit. So these are the sections that I will be looking at. Before we actually talk about the clinics, this is a slide that I want PGs to look at and get introduced to. What is it that we will be studying in a laboratory when we look at genetic abnormalities? What you see here is a chromosome. We have 46 chromosomes, and all these 46 chromosomes have a double helical structure called DNA, which has a genetic code on it. This genetic code is made up of 4 letters, A, G, C, T, and the combination of these 4 letters is called a code, which produces a protein, which performs different functions in our body. And if there is a defect on this code or at the level of the chromosome, the protein output will be defective. Either the protein will not be produced, or the protein will be produced in higher quantities or lower quantities, which will then disrupt the metabolism, and it results in a genetic disorder. So we can study genetic disorders at the level of protein. We call it as biochemical genetics. You could study your genetic disorder at the level of genetic code by looking at the DNA. We call that as molecular genetics. And if we study genetic disorders at the level of chromosomes, we call it as cytogenetics. Now with that, this is just one slide to show you the kind of technologies that are used in a genetic laboratory. This, I think, is important, probably one slide, technical slide that I usually use. If you look at this, every chromosome, if you are going to study your genetic disorder by looking at the chromosomes, we call it as karyotyping. Every one of you know that. And why do we do karyotyping? We do it to identify the number of chromosomes. If they are abnormal, we call it as aneuploidy. And this karyotyping happens through a microscope. In the sense, this is you have to culture your cells, look at the dividing cells, look at the chromosomes, and just count them. If there are less than 46, it is monosomy. If it is more than 46, you have trisomy. And sometimes through the microscope, you will also be able to visualize structural abnormalities, which are like, balanced translocations, for example, or big deletions and duplications, which are as big as 5 to 10 MB. So very big deletions and duplications that you can actually see through your eye, through a microscope, is something that you can identify through karyotyping. But then if you want to see something smaller than that, what if there is a deletion or a duplication which is, around 10 KB? KB is less than MB, right? So if you want to see such smaller deletions and duplications, you will have to take up a technology called cytomicroarray. All of you must have heard this term, cytomicroarray, which basically looks at the copy number variations, which are, in other words, called as microdeletions or microduplications. And you can actually see that as small as 50 KB deletions and duplications using cytomicroarray. This is a DNA test. This does not require you to culture your cells as karyotyping. Then the third type of test, where you want to zoom much more closer into your chromosome, you're not interested in copy number variations, but you are interested in the genetic code and the sequence of the gene. And if there are any changes in the sequence of the gene, then you would take up what is called genomic sequencing. This you can do by different methods like PCR, Sanger sequencing, or next generation sequencing. Next generation sequencing is generally done when you are looking at multiple number of genes and not a single gene, and you want to, something like a whole exome sequencing or a whole genome sequencing, or panels of genes that are created where multiple hundreds of genes can be studied. All this is now possible using next generation sequencing technology. So this is about the technology, and we'll now move on to, I thought I'll divide my lecture into certain sections. And the most important part and the most common evaluation that obstetricians would do is testing their fetal sample, especially in recurrent abortion cases or in cases where there is fetal ultrasound abnormalities. So this slide tells you that the first tier test that you should be looking at is cytomicroarray on a fetal tissue. This is the first tier test that you can, I have listed many societies here, ACMG, ESHG, CMG, AMP, etc. All these societies recommend that the first tier test should be cytomicroarray on a fetal sample. Classically, we have been doing karyotyping on fetal sample, and we all know that many a times this karyotyping, the report comes back saying there's no culture failure, when there is culture failure, and they're unable to give the result. And that is because most of the time the products that come to the laboratory are not viable, and they also come with a good amount of contamination, and therefore the best test that has come up, which replaced karyotyping of fetal samples totally, is cytomicroarray. Cytomicroarray is a DNA test, so you really don't need viable cells, and second, you really don't care about the contamination because you are separating your DNA. So this is what I just talked about. This slide shows you that, if you take up karyotyping, 80 to 90% of cases, there is no growth and it fails in the culture. That's the major limitation. And here you can see in this chart that compared to karyotyping, the number of abnormalities, just look at the last bar, the number of abnormalities that you can pick up through a cytomicroarray is much more than what you can pick up through karyotyping. Obviously, because karyotyping can only look at 10 to 10 MB size of changes, whereas cytomicroarray can give you up to 50 kb, and therefore the diagnostic yield for cytomicroarray will be much higher. And as clinicians, as PG is, you must know how the report should look like. And my general presentations and my intention of presenting to PGs is so that they are able to appreciate reports from laboratories. And the genetics should not be a foreign subject to physicians. They should be able to look at the report, feel comfortable in interpreting the report and in counseling their patients. And this is how your cytomicroarray results would look like. These are different chromosomes that we have I put up from different cases where the fetal sample was tested. In first case, you can see that there is a blue bar against the chromosome. The complete blue bar against the full chromosome means that the complete chromosome has been duplicated. When there is a blue color, it means duplication. When there is a red color that is present parallel to the complete chromosome, it means that it is monosomy. That means one of the chromosome is missing. So here the chromosome 18 is completely duplicated, so it's called Edwards syndrome. Here it's a completely deleted 1X chromosome, so therefore Turner syndrome, which is 45X. And in this case, you see that the complete trisomy of chromosome 9. Here you see that there is a microduplication. That means the blue sign that you have here indicates that only a very small part of this chromosome has been duplicated, and it results in a syndrome called Potocki-Lopsky syndrome. So similarly here, a very small part of the chromosome is deleted, resulting in Williams-Beuren syndrome. So the cytomicroarray will not only tell you about the number of chromosomes, which any karyotype would give you. In addition, it will give you the diagnosis of several microdeletions and duplications that are possibly responsible for recurrent pregnancy losses or fetal abnormalities. So therefore, the takeaway message is do cytomicroarray on all your products of conception. So I'll just give you some case examples here. A 27-year-old female, second pregnancy loss, spontaneous at 13.5 weeks, non-consanguineous marriage, no family history. Cytomicroarray on products of conception showed pathogenic 2.5 MB deletion on chromosome number 4. Now, when there is a deletion, what happens? How do we interpret the result is that how many number of genes are deleted? Here we have, there is a deletion of around 10 OMIM genes. OMIM means Online Mendelian Inheritance of Man. This is a database that is available. Any one of you can check these databases and you will see that what happens if the gene is deleted. So the genotype-phenotype correlation is provided in that database. So in that database, based on that database, around 10 OMIM genes are deleted, and most these microdeletions are due to cause early embryonic development defect, and they're sporadic and not inherited. Now, whenever we give information that it is a sporadic event, that means the recurrence risk is low, and therefore the families can be counseled that there is no risk for future pregnancies. And if there is any risk for future pregnancies, parental karyotyping can be offered. So here is one case of such nature, where there is a spontaneous pregnancy loss at 14 weeks. And we did cytomicroarray and found that there is a deletion on chromosome number 5, and there's a loss of 49 genes. And this is a pathogenic copy number variation, and it results in a syndrome called Cry-Do-Chat syndrome. Now, this, every one of you know, this is a textbook syndrome which talks about microcephaly, developmental delay, and pregnancy loss. But the issue here, the point to be understood is that 10% of these syndromes are due to balanced translocations in parents. So we have conducted parental karyotyping, and we identified that there is a balanced translocation in father. So because of the balanced translocation in father, there was a deletion in the fetus. And I will show you some slides how this can happen. And because the father has a balanced translocation, he would not be showing any symptoms of an abnormality, because it's just an exchange of material between one chromosome to the other. But when during the gametogenesis, there are errors that can happen, and therefore it could result in a deletion. Whenever there is a translocation in parents, we know that the risk for another abnormal pregnancy or pregnancy loss could be more than 15%. And therefore, in such cases, prenatal diagnosis would be mandatory. This is a case of fetal abnormalities on ultrasound. We have around 24-year-old primey, 20 weeks gestation, and we have unilateral ventriculomegaly as the indication. And cytomicroarray revealed a small deletion on 17th chromosome. And what you see here, the syndrome is called Potocki-Lobsky syndrome. This syndrome is associated with neurodevelopmental problems and congenital heart defects. Now, with when this happened, we have tested the products of conception, but we do know that this particular syndrome is an autosomal dominant disorder, and it does not have any recurrence risk. It's a sporadic event. And therefore, we have assured patients that there will not be any risk, elevated risk for future pregnancies. So anyway, ACMG also recommends, ACMG is American College of Medical Genetics, it recommends that cytomicroarray should be done as first tier test for syndromic presentation. So what do I mean by syndromic presentation is that there are multiple presentations in the fetus, multiple anomalies seen, and we are unable to actually categorize that syndrome as any Mendelian disorder. So we don't know what we are looking at. We are looking at multiple disorders. So here in this situation, first tier test should be your cytomicroarray. There are multiple conditions, ultrasound defects for which genetic association has been attributed. I cannot list more than this. That can actually go into pages. There are hundreds of microdeletion syndromes that are associated, but these are the most common ultrasound defects like absent nasal bone, echogenic bowel. Again, some of them are soft markers, some of them are very strong markers, and sometimes there can be multiple markers that can be seen. So this needs to be worked out, and there has to be a teamwork between the genetic laboratory and the consultant, so that the first tier test should be ordered as cytomicroarray or not can be decided. Most of the time it is the cytomicroarray that we look at. Now, many a times I have seen that parents' cytomicroarray is also done. And there is a misconception that array has replaced karyotyping, and instead of doing karyotyping, there are many clinics who are now ordering a parental array, and this is something that is not that actually doesn't help, and the reason being, an array will never identify a balanced translocation. It will not. Array is a DNA test, so within a cell it will take all the DNA and it will tell you, well, whether there is chromosome 1 in full, chromosome 2 in full, chromosome 3 in full, etc. It will just say that there are 46 chromosomes. It will not tell you that the chromosome number 1, a part of chromosome number 1 has translocated to chromosome number 9 and a part of chromosome number 9 has been translocated to 1. It will not talk about the exchange. When we cannot, and the most common reason for bad obstetric history or a pregnancy loss or a fetal anomaly in that for that matter is a parental translocation, which is the prevalence is around 1 in 650, right? So if the test does not identify such an important aspect for bad obstetric history, then we are just wasting patients' money and also our time. So please do not order parental array as a replacement for karyotyping, except in one situation where you see that the product of conception, in the products of conception, you see a variant of uncertain significance, that is a CNV or a microdeletion or a duplication, which does not have a definitive pathogenicity. In the sense, we are unable to say whether it's pathogenic or benign because there's limited evidence available in literature. In such a scenario, the lab will tell you to conduct a parental array, because if one of the parent harbors the same variant of uncertain significance, then we can determine that the problem that we found in POC, products of conception, is non-pathogenic. Okay, so in such rare conditions where the products show a variant of uncertain significance and we want to get to the bottom of the pathogenicity, we recommend parental array. Otherwise, what you need to do is to, if the product is not available, do a parental karyotyping, or if the product shows a terminal deletion or duplication, then please do a parental karyotype after the POC test. And many a times after we do products of conception array, we get normal report. And what does that mean? Does that mean that there is no genetic problem in the fetus? Maybe not. It just means that there is no chromosomal etiology, in the sense there is no aneuploidy or there are no microdeletions or duplications associated with pregnancy loss or fetal abnormalities. In that case, we will have to work on further testing. Follow-up tests are required. More workup will be required to understand. And in those cases, you could actually store the DNA, and this can be stored for more than 2 years in laboratories. So that, and sometimes even when patients just lose their pregnancy and they're in distress and they don't want to get tested immediately, please advise your patients to at least store the product, a DNA of the product, so that the index case is not lost. If we have the information on the index case, we can do much more good for the families compared to when we lose that index case DNA. So it's important to store the DNA of the product or of the baby who is affected, or of the neonate. So this is one point that we need to look at. Sometimes I will not go into these details because I think I have like around half an hour. So I may not go into details of all my slides, but I want to just give a glimpse also to this condition, which is called loss of heterozygosity, which can be picked up in cytomicroarrays. And this loss of heterozygosity indicates that there could be an autosomal recessive disorder possibility in the region where the heterozygosity is lost. So I'll skip this slide. And then once the fetal DNA or the fetal sample is tested, the next will be testing on the parents. As I have already elaborated, this slide shows that parental balance translocations are the most common cause for recurrent pregnancy losses, and that needs to be evaluated wherever the product is not available and ARES cannot identify your translocations. Beyond the chromosomal reasons, recurrent pregnancy losses can also be because of certain other genetic problems, which can be due to changes in thrombophilia genes, changes in immunology genes, and inflammatory apoptosis related DNA repair system, aneuploidy causing genes. There are certain genes which function on the spindle fibers of the chromosomes, and if those are defective, then the chances for aneuploidy increases much more. And there can be genes which are associated with preeclampsia, gestational diabetes, IHC, etc., which are all also part of the pregnancy loss panel. So with the advent of next generation sequencing, what has happened is that we have actually developed something called gene RPL. This is a test which identifies around, looks at around 200 genes which are associated with pregnancy loss that are maternal in nature, and based on which you can actually identify what are the risk factors, and you could tailor your treatment accordingly. For example, if there is a thrombophilia gene involved, we could think of anticoagulant dose for the patient. If it is immunology, we can think of anti-inflammatory immune support system. If there is aneuploidy, you can think of NIPT and other prenatal tests, and of course prevention of preeclampsia, etc. So again, I will not go into details of this, but I just wanted to bring to your notice, especially to PGs, that it's not just the chromosomal etiology. Chromosomal defects play a major role in pregnancy loss, but there are many other genes that are involved and that play a very important role in pregnancy maintenance. And if you see a defect or a variation there, it could increase risk of pregnancy losses. And it would be and the whole system is going towards, the way we are going forward is to identify these risks ahead of time so that the pregnancy loss can be prevented. You can do a preventive management in many of these cases. So moving forward, since I was given bad obstetric history, there is much more to bad obstetric history than pregnancy losses. So I will cover some fetal defects, family history, consanguinity, etc. in this section. So this is again a very textbook kind of slide. You all know that if the chromosomal and copy number variations are normal, then we are looking at Mendelian or single gene disorders. Mendelian disorders or single gene disorders, we inherit in mainly 3 different ways, although there are many other ways which I am not going to talk about here, but they could be autosomal dominant, they can be autosomal recessive and X-linked. And autosomal dominant is out of 2, the pair of genes that we have. If one of them has a mutation, the phenotype will be affected, the person will be affected. In an autosomal recessive condition, you need both the genes, both the copies to have the mutation. You need a double dose of mutation for a recessive disorder to express. In an X-linked recessive condition, you need, because it is recessive, women have 2 X chromosomes, and if they have mutation on 1 chromosome, they will not express it. But in males, if that X chromosome goes to the male child, because he will not have a counter X from the father, the male will be affected with the mutation. So this is X-linked recessive. So broadly, these are some of the inheritance patterns that we see. And the most important and the most complex and hidden form of genetic disorder is autosomal recessive, where parents could be carriers of these mutations. Mother could be a carrier, father also could be a carrier for the same mutation. And when these two mutations come together, then the baby will have a recessive disorder. This is very common in consanguineous marriages. This slide actually shows you that everybody shares certain amount of genetic material. In the sense, the genetic sequence could, a part of it, less than 1%, I'll be sharing with yours. But then if it's my first cousin, then I'm sharing around 1/8 of the genetic material. You can see here very clearly that the gray area represents the sharing of mutations. So the mutation, these 3 mutations are shared by this couple. So that's how the sharing of mutations happens, and therefore the risk increases. First cousins share 1/8 of genetic material, and the chances of common recessive mutations is therefore much higher. And when there are carriers, the risk of offspring to have a recessive disorder is 25%. So what do we do? Now, today, with the help of next generation sequencing technologies, we offer what is called extended carrier screening. This is a program where we look at multiple genes. I mean, previously we used to look at hundreds of genes, then a few thousands of genes, but with the costs of sequencing coming down, we are now sequencing the whole exome, and we are doing what is called carrier screening. What happens there is we sequence 20,000 genes, and we see where these two partners have matching mutations, in the sense same mutation or different mutation but on the same gene. Doing that kind of matching, we will identify risk for disorders. And many times we see that a consanguineous couple will have risk for multiple disorders, not just one disorder. Because I remember a case of thalassemia where we have told them that to come back, we did prenatal diagnosis, baby was devoid of thalassemia, we sent them back. They've come back with a child with retinitis pigmentosa. That is because at that time, this was about 15 years back, we did not have technology to actually look at every single mutation. So when we did what is called targeted mutation, because there was a history of thalassemia, we looked at thalassemia. But now there is an opportunity to actually cover complete exome, which is the expressing part of the gene, and then look at all the common mutations, and then provide them a test in the pregnancy where we can identify all risks for all these if the baby has any of these genetic disorders. Of course, pre-implantation genetic testing is also done, where if we are looking at a single mutation, we will be able to look at it in an embryo, post IVF conception embryo, and then we check on different embryos. Whichever embryo is devoid of the mutation, we then transfer that embryo. So this kind of helps, most of the time not to prevent the medical termination of the pregnancy, as you already know you are transferring a normal embryo. Of course, prenatal diagnosis is prescribed even after PGTM. So I'll not go into details of PGTM because it's not an infertility lecture, but this particular slide will help you understand how carrier screening was used in these two different cases. Both these cases had male children with hydrocephaly. Both of them the case one was non-consanguineous, case two consanguineous marriage, but both with history of male with hydrocephaly. In case one, we see that the female, we've done carrier screening. When we do carrier screening, we not only identify the autosomal recessive disorders, but we also look at X-linked disorders which can come through a female carrier mother. So here we found that the female is a carrier of X-linked hydrocephaly, and it is a 50% risk for male offspring, and we ruled out in 16th week by amniocentesis. In another case, the same history of male with hydrocephaly, we found that both the partners are heterozygous, meaning carrying one mutation each, on a CCDC88C gene, which results in an autosomal recessive hydrocephaly type 1. Now here, because it is recessive, autosomal, the risk is 25%. And here again, we have offered amniocentesis at 16th week. So based on that, we found that the baby is also a heterozygote. So the baby will be as normal as parents. This is okay. And when we do carrier screening, we know that spinal muscular atrophy is quite common in our country. Not as rare as a rare disorder. It is prevalent in a much more, in some groups much more than other. And we need to screen for spinomuscular atrophy along with the thalassemia. Thalassemia is another very common recessive disorder that we need to look at. And not all disorders need to be screened. It needs something like a NGS technology. For example, spinal muscular atrophy, you can just do a test with a simple PCR, which is much more economical, and you can offer the test to the patients, to the carrier patients, and also to the fetus. This slide I just put up because anyway, we are talking about anemia. So this is a beta thalassemia case. In beta thalassemia, the general thing to follow is we do a HB electrophoresis for the woman so that we pick up thalassemia traits, since it's one of the very common genetic disorder. Please do HB electrophoresis on all females so that if you know that the female has a trait, then you can also offer carrier HB electrophoresis for the male partner. If both male and female partners have been identified to be having the trait of thalassemia or sickle cell anemia, then you offer what is called prenatal diagnosis. It's better that both the parents could also get what is called full gene sequencing of beta globin. Beta globin gene is the gene that is responsible for beta thalassemia. So if you sequence beta globin gene, it's a very small gene, so it does not require next generation sequencing. And then we can identify the mutations on it. And once the mutations are identified in parents, it's very easy to offer targeted genetic testing in amniotic fluid. So this is very important as a preventive measure. Please do HB electrophoresis on females, pick up traits, and then prevent thalassemia in children. Another very common condition that we see in our laboratory, very common indication that we counsel patients for, is deafness and hearing loss. Yes, so when you see deafness and hearing loss, this chart actually gives you a good idea that around 25% are idiopathic, 25 are non-genetic, and 50% are genetic. So the first counseling step, the first level, you can always tell the family that 50% is genetic and 50% is not. And out of the 50% genetic cases that we see, 70% are non-syndromic and 30% are syndromic. So if you see a case with 30% section, which is syndromic in the sense along with hearing loss, they also have mental retardation or maybe dysmorphology or limb defect or ophthalmic condition. So there are other symptoms also that you see. Then you please refer for cytomicroarray. You please do a cytomicroarray test. Why? So, because cytomicroarray looks at copy number variations, which are much bigger. So when you are seeing multiple conditions, syndromic presentation, that means maybe more than one gene is involved. This is possible. And therefore, the first tier test should be cytomicroarray. Of course, if this is normal, you can always come back to exome sequencing, where you are sequencing number of genes, a large number, more than 100, 200 genes that are associated with non-syndromic hearing loss. So if it is non-syndromic, if they just present hearing loss, then you go in for exome sequencing. Once you do exome sequencing, you will be able to pick up recessive disorders or dominant or X-linked. And please note that around 75% are autosomal recessive in nature. That is why we see a lot of hearing loss related cases in consanguineous marriages, because a large percentage of non-syndromic hearing loss is because of autosomal recessive disorders. Similarly, we have again, this slide I have put up for PGs to understand how to read their reports, like I did the other slides where you should be able to look at the sequence yourself. Here, I am just showing you a case of Duchenne muscular dystrophy where the mother is a carrier and the child is affected. So you can actually see this red line, which corresponds to 0.5. That means half of the area is present and the rest half is deleted. Anyway, females have 2 X chromosomes, right? So if it means that they have only 0.5, that means the deletion is present in 1 chromosome only. The other chromosome is normal. Now, in the child, in the male child, if you see, this half has become 0. That means the female has given the X chromosome to the male child, and because he will not have another counter, the partner X, he will have a Y chromosome. Therefore, the complete deletion is seen at the level of 0. So this is how you need to familiarize yourself with these reports. And when you get your lab reports, you need to have all this information, and you should be able to clearly look at this and tell that this is a carrier and this is an affected individual. In this case, what we are seeing is that the female is a carrier where the exon 8 to 44, look at the number of genes, exons that are deleted. Exons are the expressing parts of the genes. So continuous, starting from 8 to 44, all those parts are totally deleted. And we also found that the fetus is affected with DMD in this condition. You can clearly see the affected fetus has 0 value for those exons. Maybe just 1 or 2 more cases, I think. This case, autism, mental retardation, developmental issues, these are again some of the very common problems that we see in our practice where there is family history. And when there is autism or mental retardation or developmental problems, which can be both moderate to severe, the first tier test is cytomicroarray. So here we have a case where 3-year-old autism spectrum disorder, we did a cytomicroarray and we identified a deletion. And we know that the recurrence risk is extremely low, and we have counseled the family accordingly. But there are also cases where the cytomicroarray can give a normal result. So if you see here, the 3-year-old autism spectrum case where the cytomicroarray is normal, there are no copy number variations. We have done exome sequencing as a second tier test. So in India, obviously, patients cannot spend on multiple tests at a time. So what we do, what is called a serial testing. Once we do cytomicroarray, if that is normal, then we're going for exome sequencing. Exome sequencing was offered in this case, and we found a recessive mutation on SHANK3. SHANK3 is a very important gene and very common gene where we see association with autism. And because both the parents had the mutation in half a dose, there is a risk for next pregnancy, which is 25%. And this is the case for prenatal diagnosis. And this has to be done by targeted mutation testing. Once we know that this is the gene that is associated, in next pregnancy, you don't have to do a complete exome sequencing. We can just do a targeted sequencing and identify the problems. So I'll just cover a little bit about your NIPT also, which, I thought PGs should know. NIPT, NIPS that we call these days is a non-invasive prenatal screening program where we are able to identify chromosomal aneuploidy the risk for chromosomal aneuploidy by looking at the fragmented DNA, that is fetal DNA, that is present in maternal blood. Now, what happens here is we quantify the DNA that is present in the maternal serum plasma, and we identify the risk for all the chromosomal abnormalities. As you can see here in this picture, you can see that the patient is lying in the low risk region, here in low risk region, in the low risk region. But if you see this spot in the red area, that means the patient has high risk for that particular chromosome. And this is how you should see your reports for NIPT. NIPT or NIPS is used both as primary screen or as secondary screen. In many of the countries, NIPT is offered as the first screening program after 10 weeks. And if that is how it is done, if it is low risk, there is no need to do anything. You can do a routine follow-up. But if NIPT result shows high risk for any aneuploidy increase, either whether it could be a monosomy or a trisomy, then you have to confirm it with amniocentesis procedure. Or now you may ask why NIPT is being extremely sensitive. It gives you around 97 to 98% of sensitivity. It picks up aneuploidy very well. Why do we still need amniocentesis, right? So it's important to do amniocentesis because the NIPT could have a false positive result, especially if there is a placental mosaicism. So the trisomy condition could be coming from the placenta and not from the fetus per se. This happens in a very rare condition, but this can happen. And because of the technological issues of how many times the sequencing has been done, how much coverage, what is the depth and things like that, there is always a small possibility. And because we are sequencing multiple areas of the chromosomes, and that is the reason why amniocentesis should be done and aneuploidy should be confirmed. However, when we do amniocentesis for only NIPTs for aneuploidy, then the number of amniocentesis procedures are generally reduced all over the world for checking for aneuploidy. NIPT can also be used as a secondary screen. What is secondary screen? You use your regular marker testing like double marker, triple marker, or a quadruple marker. If the risk is high, if the double marker shows high risk, then you can go in for NIPT. And if the double marker shows low risk, there's no need to go in for NIPT if it's used as a secondary screen. If the double marker is high risk, then you can take up NIPT instead of amniocentesis. If NIPT shows high risk, then we can go in for amniocentesis. Now, this I am talking only about aneuploidy screening. But if you see in your ultrasound abnormalities any other marker which is associated with either aneuploidy or any other genetic syndrome, then NIPT is not the answer. Then we will have to directly go in for amniocentesis, and we will have to probably do an array test or an exome sequencing test, depending on the presentation of the ultrasound findings that are seen in the pregnancy. So for regular aneuploidy, if a high-risk screen marker test, you could use NIPT, and if NIPT is normal, then you can simply consider the double marker or a quadruple test as a false positive result. This again, I have covered this at any point of time. It's very difficult to squeeze all cases of genetics into a small 30-minute lecture, but remember that we have to have the crucial information stored, in the sense the index case or the proband, which could be in the form of amniotic fluid or a product of conception or a newborn baby or an adult, we have to have the index case DNA stored. That helps quite a bit in understanding the disease-causing mutation in the family and preventing it for all the members who are at risk. And okay, this is sample collection, I am not going into details of sample collection, but everybody would know how to collect the sample. For cytogenetics, it's sodium heparin. For any genetic test, it is EDTA, and amniotic fluids and sterile tubes. CVS, we will provide the media and products of conception in normal saline, etc. But the important point here is that if you are sending the sample to a laboratory for molecular testing, which is DNA-based testing, like cytomicroarray or exome sequencing or targeted sequencing, you need to send mother's blood also along with the fetal sample. That is because we don't want the maternal DNA contamination in the fetal sample. So if you can send 3 ml of in EDTA tube, then we do the quality check and we identify that there is no mixing of DNA from the mother, and we are sure that what result we are giving is of the fetus and of the product. So, but this will not be required if you are sending sample for karyotyping, because in karyotyping, what happens, we culture the cells and only fetal cells grow in culture and the maternal cells will not grow anyway. So for DNA tests, you have to send maternal sample. So that's one of the important things that I just wanted to tell you. But what is more important is counseling. We need to spend time with the patient. We need to talk to the patient. What happens in genetic counseling? I just put up this slide to just show you what happens. Basically, a genetic counselor will, study the medical records. They will look at the case history. They will check the physical. They will do physical examination, and they will see the proband or the index case, and they will take the phenotype details. They will check into the databases and they will retrieve genetic database information so that it says, okay, these are the 10 syndromes that you should look at. We also take 3-generation pedigree to understand the inheritance pattern, whether it could be recessive, dominant, or X-linked. Of course, the use of databases is done. And then we have to talk about the risk estimation. So what is the risk for next pregnancy, or such things have to be understood, and what will be the prognosis if there is a syndrome that we have identified, what will be the prognosis after 10 years, after 20 years. This information should be given. We have to recommend the options for the family, and what tests to be done, and how to evaluate the test results and explain the test results to the patient. And the most important thing is a detailed letter that should be given to the physician. Please expect a detailed letter from genetic counseling sessions. It's not just writing on the paper, but it has to be a documented, clear communication, because the communication is not just with the patient. The communication of the genetic counselor is with the physician, because the recommendations will have to be followed by the physician. So a clear cut case history, case description and recommendations and follow-up studies. And you need to expect genetic counseling letters, not only in test recommendation, but also for post-test recommendations. So once the test comes, how will you actually give this information to the patient, and what will you recommend from there onwards? This is also very, very important. So these days a lot of online counseling happens, and it's very important that genetic counseling becomes part of the obstetric practice, and the collaboration should be very important with a good geneticist. Thank you so much. I have put everything in 30 minutes, but I must have crossed 30 minutes. I have not seen the timings. If you have any questions, I'll be more than happy to answer.
Dr. Aruza, it was a wonderful talk.
Thank you so much. Please let me know if you have any questions.
Jignesh, before that, can we have one photograph?
Can I stop sharing my screen?
Yes. Thank you, Anuradha ma'am, for such a lucid presentation, and you made this all easy for us. All common tests like karyotype different advanced tests like cytomicroarray and clinical exome sequencing that we do. Important thing for such a couple with bad obstetric history is we should be patient to diagnose the case, as we need to give the good prognosis for the future pregnancy. In couple with bad obstetric history, we should vigilant about the counseling and detailed history extracting and suspecting the etiological factors, so that we can give like in ultrasound we use the ALARA principle. So in such cases we should finalize and precisely offer them such tests so that it will benefit for the decision making and informed choices for them for the further planning of future pregnancy and its outcome. So commonly we use karyotype for many as a couple karyotype and even the prenatal testing for diagnosis of aneuploidy. Secondly, if a couple comes with a bad obstetric history like previous 2 losses, 3 losses, means babies die after birth, 6 months, 7 months or some years. So in such cases, we need to extract the history. We give them, offer them some advanced tests like microarray. We can give clinical exome sequencing. So karyotype is not the answer for everything. That is very basic test. So we need to give them a proper test, proper discussion, informed choices for them, and ultimately finalizing them, planning of pregnancy and further outcome, because they have already a abnormal child like autistic or have a different genetic phenotypical affected case. So in such cases, it's our duty to give them a healthy child by diagnosing it at early 11 to 12 weeks of gestation and give them a better outcome for them. So different tests are there, and we need to be patiently diagnose these cases as etiological factor and give them the informed choices. Then for POCs, we routinely offering them the cytomicroarray nowadays. For stereotype, mostly the contaminated sample and the test results are not valid. So cytomicroarray is the best thing to go for POCs analysis. Then genetic storage is also option if patient is not affording at that stage. We have a limit of 18 months so they can arrange their finances. And we have the ample time to discuss the history and take the help of geneticists also. And accordingly, we can have the test on DNA storage material. And for next pregnancy, we can give them the better choices for planning and executing the diagnosis of that pregnancy. Also,
Here, I just wanted to just tell you something that many a times as you mentioned, Dr. Kunda, karyotyping is the most basic test. But many a times what happens, there was a case where there is consanguinity and they have had a previous neonatal demise, and the case has come to us at a later point. They've come with carrier screening, and some variations were identified in carrier screening, but they did not correlate with the neonatal demise phenotype of the previous history. And this couple did not go through karyotyping. And when we did karyotyping, they had a balanced translocation. So don't forget the basic tests. You must ensure that karyotyping is done, whether it is a consanguineous couple or a non-consanguineous couple. And then if the karyotype is normal, then we will have to go into looking for, other deeper problems which could be lying in the genetic code. Of course, for consanguinity, carrier screening is something that's strongly recommended.
We should go step by step, and in consanguinity, if bad obstetric history is there, we should be going by step there. But if the baby is having like autism or different genetic problems, then we must go for clinical exome sequencing from them and targeted mutation for the future pregnancy, if at all is there pathogenic targeted mutation. So different box is there. So we need to find out which test we should offer with minimum cost to the patient and maximum prognosis outcome decision making as the informed choices to the couple. So
that is where a teamwork will be required, where you could work with the genetic laboratory, genetic counselor, and the physician, and maybe the pediatrician also, if there is a index case or a baby available, and that kind of teamwork, I think, will do a lot of good to the patients.
Yeah, one case I want to share, ma'am.
Yes.
One of the doctor patient and from outside actually done IVF. Then she come with a screen positive and done microarray in the test, and it was all aneuploidy normal, but come like some deletion on the microarray on some chromosome.
Yeah.
So it was like every most of the geneticists suggested that we should terminate because this is a big chunk of chromosome genes which are lost. So the 2-3 days they are planning to terminate the pregnancy, and then suddenly that lady thought that the genes were related to the skin disease, mild skin disease, and it was pathogenic. But we didn't know what the loss is more and what will be the prognosis related to that condition. Then 2-3 days we have asked detailed history and everything, but she said no regarding that. Then suddenly she could correlate with her father, that her father is having the skin disease, mild skin disease, and he was not affected by other way, and he was with good like phenotypically just with the skin disease, and otherwise he is okay. So we did similar test on his father, and we could know that the same thing is with the fetus. Then mother is the carrier for that thing, and the baby is having the same genes, whatever her father is there. So we took the decision of continuation of pregnancy, and the baby is fine now.
Yeah. So this usually happens when there is a variant of uncertain significance. It does not usually happen with a pathogenic variation. So this is very interesting. If a pathogenic variation has a normal phenotype, this qualifies for a publication.
Yes, actually, when we know the prognosis of the thing, so then we can at the most surely can tell that prognosis will be good, because we don't know that small chunk of genes which lost that can functionally is a big problem for the fetus. So if we know that if we are comparing the things, then we can give them a good option for them what continuation of pregnancy and prognosis will be good. So that is good that we have nowadays we have this test, we can go forward and give a good outcome for the pregnancy, even the VOH patients.
Many a times patients come to us in a very late gestation where there is no time to really do any of these serial testing. So the best scenario would be to evaluate the parents before pregnancy. That would be the idealistic situation. Most ideal situation. If that is not possible, at least evaluate them as early as possible in the early pregnancy, so that you have some time for your carrier screening results to come and things like that. But if you see an abnormal fetus, then you will have to ask the lab to expedite the results as soon as possible, so that you can take quick decisions on continuation of the pregnancy or not. And these tests usually take around 2 weeks to 4 weeks, and therefore we need to plan properly so that we can do the best at the right time for the pregnant woman.
Yes, pre-conceptional counseling is very important. So each and every patient has this with bad obstetric history or this, we can make a management before pre-conception, and then we can do all the tests and then plan accordingly, so that we can get targeted mutation early at the 11 to 12 weeks of time. So it's a good discussion. Thank you so much.
It was very nice. Can you please stop sharing so that we can have photograph? Jignesh? Mitali? Done? Mithal, it is done? Jignesh,
Yes.
it is done?
Yes, ma'am.
Okay.
Thank you.
Thank you. Thank you very much.
Thank you.
Thank you so
It was
much.
very nice.
Thank you, Dr. Kunda. Thank you, everyone.
Ma'am,
Thank
for
you.
updating us.
Night, everyone.
Thank you, Shani. Now I request Dr. Pragati Kanatkar ma'am to please give the vote of thanks.
Thank you, Kritika. So at the onset, I should congratulate Team Energist for organizing this learning series, really lighting the lamp of education, which our president always dreamt of. And that lamp is really lit day by day. It's getting brighter and it's illuminating all over the globe. So I thank Dr. Shushma Deshmukh for such a wonderful idea of PG Star. Then I should thank today's speaker, Dr. Anu Udimudi. Madam, this was such a complex topic, and we all, we general obstetricians are always so scared of all these genetics and all the studies. You have made it so simple, and your slides were so speaking and so easy to understand slides. So thank you for such a nice presentation and making this subject so clear to all of us.
Thank you so much.
I thank Dr. Kunda Shahane and Dr. Aparna Vahane for being chairing today's session. Your inputs were so important to understand those complex cases. Diksha, you presented the case very well, and it was a good learning opportunity. Thank you for presentation. Kritika, you were good MOC. Thank you for taking the case throughout. You were very fast. Our president couldn't welcome, and you had done the case very well. Thank you so much. And I should thank GMC Akola. I should thank Dr. Prachi Dikshit, Dr. Bhakti Guzar, and our leader, Dr. Anuja Bhalerao, for initiating such an PG activity throughout the country. Thank you so much. And today's examiner, Dr. Anjali Kotharkar and Dr. Virendra Kumar has really put a good insight in such a day-to-day common topic of anemia in pregnancy. And there was so much of learning and so many simple things as well as so many things for the PGs to learn. Thank you so much. And last but not the least, all the delegates who are logged in, thank you for logging and getting yourself updated. Thank you all. Good night.
Good night.
Okay.
Everybody.
Bye-bye.